Hemodynamic, and Dr. Awadelkarim Elneama. Surely you know him before, and he's consultant cardiologist and in advanced cardiac imaging in King Abdulaziz Medical City. I think he had a comprehensive review of hemodynamics in this session. So the last session we have done is kind of foundational, and Dr. Awad will continue on that and will take you through almost all of the hemodynamic data you are going to encounter in cardiology. Dr. Awad, the screen is yours, the mic is yours, and the time is totally yours. So you can start.
Okay, thank you, Hatim. Welcome, our audience. It is my pleasure to be with you this evening, just to discuss and learn with each other some about invasive hemodynamics. So,
just to remind you to start recording, and we are going to take it.
There is recording already, ongoing recording. Okay. So as I knew from Hatim last session, you went through some introduction for the hemodynamics. Now I can just review with you quickly the indication, which can be diagnostic or therapeutic for hemodynamics or invasive hemodynamics. And one of the common indication is to clarify the cause of shock or pulmonary edema in ill patients. Also to study for pulmonary hypertension and its severity. One of the major indications for hemodynamics is to guide fluid management and hemodynamics monitoring, especially after cardiac surgery or after complicated myocardial infarction or in cardiogenic shock status. Hemodynamics also indicated for diagnosis of shunts. This could be intracardiac, extracardiac, it could be left to right or right to left shunt. So hemodynamics help a lot in studying shunt. Also, one of the major uses for hemodynamics is to measure the cardiac output, and this will be a separate topic. There are many methods for calculating cardiac output using hemodynamics. Also to assess for the valve lesion and its significance or severity. Again, differentiating constrictive pericarditis from restrictive cardiomyopathy is one of the main indications for invasive hemodynamics. There are a lot of indications. Among them, this seems the most common indication for hemodynamics. When you are recording hemodynamics, you have to be cautious in case of pulmonary hypertension in elderly patients and in patients with left bundle branch block. Because usually when we do hemodynamics, we do it from the right side. This is the common. So if the patient has left bundle branch block, one of the complications of doing hemodynamics, the patient may develop right bundle branch block. And if he already has left bundle branch block, this may lead to complete heart block and may necessitate you to put a transvenous temporary pacemaker. Among the complications for hemodynamics, we have the venous-related axis like hematoma, pseudoaneurysm, or local complication from the venous axis. Arrhythmias usually arise from RVOT stimulation during passing the Swan-Ganz, and this may include VT. Usually are transient, not significant, and do not require treatment. Most of the time are self-limited and can be alleviated by catheter readjustment. Also, AV block and right ventral branch block, as we said, because this is the AV node in the right atrium, when passing the catheter in the right atrium, your hemodynamics may be complicated by AV block or right bundle branch block. So regarding the equipment, what is on our left hand is the Swan-Ganz catheter. And I think Hatim already discussed with you the parts of the Swan-Ganz, and it is usually used for right side hemodynamics recording. On our right hand, this is called Behrman catheter. It is used for hemodynamics and used for angiography at the same time. These are the parts of the Swan-Ganz catheter. Just to remind you, it is a balloon tip catheter. This is an inflated balloon, so it can ease the passage of the balloon with blood flow. So we have this valve, and this is the inflation. The balloon will be inflated from here, and there is a valve. We have thermistor here. This to check the body core temperature when we are calculating the cardiac output. This is the proximal lumen and the distal lumen. We are not going to go in details for this because I'm sure Dr. Hatim mentioned something about it. So in doing and reading and analyzing hemodynamics, you have to have a systematic approach. You have to have full technical orientation or to know the technical aspects. So you have to establish a zero level and balance the transducer. You have to confirm the scale of the recording. For example, if you are recording from right heart cath, it's usually around 0 to 40 or 40 plus. And if it is from left heart cath, usually around 0 to 200. Then you have to collect your hemodynamics in a systematic method using established protocol. This depends on the question from the study. And you have to assess the pressure waveforms. We are going to go through the waveforms of different hemodynamics and of different chambers and vessels. It is important to time your hemodynamic pressure waves with an ECG so you can know the systole and diastole. And also you have to review for artifacts, and you have to have an idea about the common artifacts in hemodynamic tracing. So just as a reminder, these are the normal values for the left and right heart pressures. For example, in the right atrium, usually right atrium is a mean around 5. RV is phasic. It means it has systolic and diastolic means for the pressure. It's the same like pulmonary artery, like LV, and like aorta. It is phasic, systolic, and diastolic. The atria have mean, pulmonary capillary wedge pressure has a mean. Just you have to put at the back of your mind the normal values, so this will help you in interpreting your findings. So let us start with right heart catheterization. Usually we go for the right heart catheterization either from superior vena cava or inferior vena cava to the right atrium. And as we said, we have to time our tracing with the ECG. And as a concept, usually electrical events precede mechanical events. So when analyzing your waveforms with the ECG, put in your mind mechanical events. These form of waves became a bit later than the electrical activity. So in the right atrial wave, hemodynamic waves, we have the atrial wave. This is increase in pressure. It is coincides with atrial contraction, followed by X descent. This X descent is interrupted by C wave. C wave, it's due to the movement of the AV valve or tricuspid valve towards the atrium. And the X descent, it is due to the fall in the pressure in the right atrium, and it is caused by atrial relaxation. So A, atrial contraction, X, atrial relaxation. This atrial relaxation is interrupted by a C wave due to bulging of tricuspid valve into the right atrium. Then followed by V wave, which represent ventricular systole, and followed by Y descent. This is due to the opening of the tricuspid valve. So we have two waves and two descent, A and V waves, X and Y descent. This is for the right atrial pressure. Usually the A wave, because in the ECG, the atrial contraction coincides with the P wave, but the A wave will see it as the PR interval. And the V wave, which coincides with ventricular contraction, it is seen with the TP interval or following the T wave. Also, bear in mind, the right side pressures change with inspiration and expiration. So the X and Y descent become more prominent during inspiration. So if you find tracing for the right atrium like this with deep descent, get an idea this is most likely inspiration. This is expiration, this is again inspiration. Also, in patient of atrial fibrillation, if we concentrate on this ECG, there is no P waves. This is atrial fibrillation. There is persistence of the descent, X and Y descent, but there is no A wave. There is loss of A wave because there is no atrial contraction. So going from the right atrium, crossing the tricuspid valve, now we'll go to the RV. Bear in mind the normal RV pressure around 25 systolic over 5 diastolic. So this is the shape of the RV hemodynamic tracing. Pay attention for example. Sorry. If you have, for example, pulmonary hypertension, the RV systolic pressure will be very high, normal up to 25. Here in the upper right, we can see there is systolic blood pressure of more than 60. So this is RV tracing in case of pulmonary hypertension. Also, pay attention for the pulmonary then from the RV, we'll go to pulmonary artery. The pulmonary artery usually around 25 over 10 with mean of 10 to 20. And there is dicrotic notch in the descending limb of the pulmonary artery pressure. Okay, just to differentiate the arterial from ventricular tracing, pay attention for the dicrotic notch. And the dicrotic notch represents the closure of the pulmonary valve, also seen in the aorta later on. Then from the pulmonary artery, we'll go to the pulmonary capillary wedge pressure, and it is closely resembling the left atrial pressure. There are some minor differences between left atrial and wedge pressure in the form that the wedge pressure became a bit later than the left atrial pressure, and its value is a bit lower than left atrial pressure, but usually resemble each other. So there is a bit time delay on the pulmonary capillary wedge pressure and relatively damped appearance of the pulmonary capillary wedge pressure or slightly lower pressure compared to the left atrial pressure. So for the left heart catheterization, we have just to review the cardiac cycle. Here is the cardiac cycle, the ECG. We have the aorta, LV, and left atrium. Just taking the phases of cardiac cycle, we have atrial contraction. This is if we look at the left atrial pressure, it is the A wave, followed by isovolumic contraction, and then rapid ejection and reduced ejection. This is the systolic phase, followed by isovolumic relaxation, and then rapid ventricular filling and reduced ventricular filling. So we have to time plot these events of the left atrium, left ventricle, and aorta to each other and to the cardiac cycle. So before systole, we have isovolumetric contraction, and before diastole, we have isovolumetric relaxation. Starting with aorta, this is the hemodynamic tracing of the aorta, and the arrow here is pointing to the dicrotic notch coinciding with the closure of the aortic valve. Normal pressure for aorta is around 120/80. So the dicrotic notch, very important in the descending limb of the hemodynamic tracing or pressure. So sometimes you can see a notch in the ascending limb, and this is called anacrotic notch. Anacrotic notch, it can occur with severe aortic regurgitation and premature closure of the aortic valve. Also can be seen in cases of severe aortic stenosis due to turbulence of blood flow during ejection. Again, we can see on the lower left in our right hand lower image, this is a pullback from LV. It is written here LV, and this is aorta with a systolic gradient, because normally there is no systolic gradient between LV and aorta, both of which have systolic pressure of around 120. But here we have the LV systolic pressure higher than aortic systolic pressure. There is systolic gradient. And also looking at the aortic pressure, it is slow rising and it is short. So there is systolic gradient between LV and aorta, and this aortic pulse is called pulsus barbus and tardus. It is diagnostic for aortic stenosis. So this is what about the aorta. Then from aorta, we will push our catheter down to the LV. We will see this tracing of the LV. Normal values are around 120/10. So in this image, there is high LV-EDP. So this arrow points to LV and diastolic pressure, which is high in this tracing. So we will come, for example, for this. The most important thing is to describe the hemodynamics. You have to analyze the hemodynamics with all information given to you. So at the end, you can put all together and reach a diagnosis. I select some example for a typical description for hemodynamics. I don't know what is the format of the exam for you, but I think if you describe all the findings and reach a diagnosis, you can answer any question in any way, because you will have all the finding together and you describe the finding. So from here, I want it to be interactive. So I will ask someone to describe what is he seeing. And don't forget, this is a teaching session. It is not a formal lecture. So from here going on, inshallah, will be interactive. And I need your participation with description. So who can take this one and describe what he is seeing?
Okay, I can take it, Dr. Awad.
Okay, go ahead. You can just anyone tell his name, so it will be easy for us. Okay, who?
Okay, Muawiyah. This is Muawiyah.
Go ahead, Muawiyah.
So this is a tracing between the LV and the left atrium, or the pulmonary capillary wedge pressure.
Good. Because it is written here LV and written here pulmonary capillary wedge pressure, we can take it as left atrial pressure. Good?
Yes. So it seems there is a gradient, diastolic gradient between the LV and the left atrium.
Good.
So this indicates mitral stenosis, severe mitral stenosis, because it gives us here the peak around 40 for the pulmonary capillary wedge pressure.
Good, so good. What other? Yeah, you did well. So let us be more systematic. I need it descriptive. What we see, we have to have a protocol, for example. And I suggest for you to start with usually hemodynamics, either simultaneous hemodynamic tracing or, for example, pullback. Simultaneous means what? We are recording hemodynamics from two chambers or a chamber and a vessel at the same time, simultaneous. Or we are using two catheters at the same time. Or it can be a pullback, for example, using only one catheter moving from one chamber to another chamber or a vessel. Here we can see the hemodynamic tracing for LV and pulmonary capillary wedge pressure at the same time. So I will say simultaneous hemodynamic tracing of LV and pulmonary capillary wedge pressure. Then I will go to the scale. It is written here 0 to 40 in a scale of 0 to 40 plus. For example, with ECG, this is the ECG. It is written ECG. I have to mention this is with ECG, and also to comment on the ECG, whether this is ECG in sinus rhythm or in atrial fibrillation, because it will give some information. So if I concentrate on this ECG, it is in atrial fibrillation. There is no P wave, RR interval are irregular, or there is this ECG is in atrial fibrillation. So I will go simultaneous hemodynamic tracing of LV, pulmonary capillary wedge pressure in a scale of 0 to 40 with ECG tracing showing atrial fibrillation. Then I come to analyze each one. For the LV, for example, all pulmonary capillary wedge pressure. The pulmonary capillary wedge pressure, what is a striking feature on this pulmonary capillary wedge pressure? Usually, the A wave will come with the ascending limb of the LV. The V wave will come with the descending limb of the LV. So here, I cannot see A wave. This confirms my diagnosis of atrial fibrillation. There is no A wave, but there is high V wave. The V wave more than 40. This indicating high pulmonary capillary wedge pressure or high left atrial pressure. And it has a meaning. So now ECG going with the absence of A wave, this is atrial fibrillation, confirmed. The pulmonary capillary wedge pressure, there is a prominent V wave, almost of 40 or more than 40, for example, of 50. This prominent V wave in pulmonary capillary wedge pressure indicate significant MR. What caused high pressure in the left atrium when plotted with the LV, and the LV EDP is around, for example, maybe 10, 15, it is not that so high. So high V wave indicating significant or severe MR. When coming to the LV, there is significant diastolic gradient. So I have this systole, this is ascending and descending limb, this is the systole. The shaded area is the diastolic gradient between LV and pulmonary capillary wedge pressure or the left atrium. There is significant diastolic gradient between LA and LV indicating significant MS. The LV ATP is around 15, maybe here around 15. And here I know it is high, the LVDP, because of significant MR, because I have a high V wave in the pulmonary capillary wedge pressure. So now I can come to a diagnosis, atrial fibrillation, significant or severe MS, significant or severe MR, most likely patient has rheumatic heart disease. So just my advice, try to adopt a protocol in describing the hemodynamics. You did well, Muawiyah. We can see this is the ideal description of the hemodynamic tracing we have seen. Okay, any question before going to the other example? This is what we said. Who can take this one? Try to describe what you are seeing.
الو السلام عليكم دكتور، كيف حالك؟
وعليكم السلام، الله يسلمك.
مساء الخير. انا والله معلش لظرف ما تاخرت يا داب دخلت فما حضرت البريفيوس وان، يعني اذا possible ان شاء الله في minute you can give me
go ahead. We are here for learning inshallah. No criticism at all.
جزاك الله خير.
It is your session. Okay, go ahead.
لا I need the previous what I didn't attend يعني.
The previous one? Okay. So this is the hemodynamic tracing between LV and pulmonary capillary wedge pressure اللي هو left atrium here resembling left atrium in a scale of 0 to 40 with ECG tracing in atrial fibrillation. So in the pulmonary capillary wedge pressure showed high V wave consistent with diagnosis of severe MR. The LVEDP is around 10 to 15 or maybe 20. It is a bit high, supporting diagnosis of severe MR. There is a diastolic gradient between the LV, resembled by pulmonary capillary wedge pressure, and LV. This is suggestive or consistent with diagnosis of significant or severe MS. So our final diagnosis is atrial fibrillation, significant MS, significant MR, most likely in a background of rheumatic heart disease. So because we have a lot of examples, let us move forward. Who can take this one? Feel free, we are learning here. There is no criticism. Okay, go ahead.
Okay, I think this is a pullback catheter.
Try to be systematic. يعني describe pull back from where?
Okay, we have in the left side you have LV.
Okay, and on the right side?
And on the right side you have aorta.
So I will say hemodynamic tracing showing pull back from LV to aorta. In a scale of what?
Scale of 0
to 200.
Yes, 0 to 200, yes.
So
with
simultaneous ECG. Let us be systematic. With simultaneous ECG.
Yes, with simultaneous ECG.
ECG showing what?
ECG showing it is sinus rhythm and regular.
It is sinus tachycardia. It is sinus tachycardia.
Yes.
So with simultaneous ECG tracing showing sinus tachycardia, because this has a meaning also. Okay, then describe the LV, describes the aorta, and get the LV showing.
Okay, the LV showing the peak pressure up to, I think, 170 or 180.
Okay, in all beats?
No, not in all beats, in alternate way.
Yeah, there is beat to beat variation, and
yes,
the peak LV systolic pressure may be around, for example, if this is 150 dips, maybe 160, 180. Okay, and what about diastolic?
And the diastolic, okay, 50, around 50.
Around 50. He gives you this arrow, and so there is beat to beat variation, and there is, what about LVEDP of 50? Is it normal or abnormal?
There is.
We see the LV pressure around 120 systolic over 10 diastolic. So LVDP of 50 is high.
Is high. Yeah, there is high LVDP.
Okay.
So we have diastolic problem most likely.
We have high LVDP.
Yeah.
Okay. What about aorta?
For the aorta, also the same. There is beat to beat variation.
Okay, good.
Also, yeah, so also the maximum maybe up to 170, 180.
Systolic, around 160 to 180. Good.
Yes. Yes.
And diastolic aortic pressure?
Diastolic around 100 to 110.
Okay. So now try to put it all together. So I can make use of the ECG. ECG, sinus tachycardia.
Yes.
I have beat-to-beat variation. What we call is this usually? Pulsus alternus.
Pulsus alternus, yes.
So I have pulsus alternus on both LV and aorta. I have sinus tachycardia, and I have high LV EDP. So what is your diagnosis?
Most likely it is pericardial effusion or tamponade.
Severe LV dysfunction.
Yeah, this is severe LV systolic dysfunction causing pulsus alternus, sinus tachycardia, and high LV EDP. Good, well done. This is the typical description. Hemodynamic tracing showing pullback from LV to aorta in a scale of 0 to 200 with simultaneous ECG tracing showing sinus tachycardia. LV peak systolic 160 to 180, exactly what we said, with a beat-to-beat variation. LVDP is high at 50. This is the arrow for the LVDP. Aorta peak systolic pressure 160 to 180, and diastolic pressure of 100 to 110. Aortic pressure also shows beat-to-beat variation, indicating pulsus alternus, because we are feeling the pulse from aorta. So in the aorta, this is pulsus alternus. So diagnosis, severe LV dystolic, severe LV dysfunction with left ventricular failure. Good, well done. Who can take this one? No, we are discussing and we are learning.
Okay,
yes.
Thank you. Okay,
welcome. Who can take this one?
Yes, I am here.
Okay, go ahead.
This is hemodynamic tracing.
Is it simultaneous, pullback, or try to be organized? Simultaneous hemodynamic tracing of what chamber, what vessels?
Aorta, the LV.
LV and aorta.
Showing
in a scale. No. Before, just try to collect the finding, then to reach the diagnosis. If you are asked about diagnosis, it is okay. You can read all it and then put the diagnosis. But now we are using this example as typical description for hemodynamic waves. So simultaneous hemodynamic tracing between LV aorta in a scale of 0 to 200 with ECG tracing in normal sinus rhythm. Okay, then come to the LV to aorta, and what is the finding? LV pressure around
the LV and
of the LV and aorta between 0 to 100.
To 200. Yeah, good.
Yes. Showing chronic aortic regurgitation.
So describe the LV. Let us concentrate on the LV. What is the LV pressure here? Systolic and diastolic.
200.
200 systolic
is 200.
And this is one.
Yes.
Around 10. The LV EDP is around 10. So it is written here, systolic ejection period. So for the LV, it is normal to have systolic 120, diastolic 10. This is the LV. Here is the systolic ejection period. In other words, this is the systole. If you plot it with the ECG from the QRS complex to the T wave is systole. We said electrical event come a bit earlier than mechanical event. So this is systole and this is diastole. So LV 200 over 10. What about aorta? What is the aortic pressure here? So each line is around 40. So 40, 80, 120, 160, 200. So here is 80, here is 120. Systolic aortic pressure is around 100, okay? And the systolic aortic pressure is around 60. Okay, aortic pressure is around 100 over 60. So let us concentrate on systole. What is the shaded area here?
This is the mean gradient between the aorta and the LV.
So there is systolic gradient.
Gradient, yes.
There is systolic gradient. We are not talking about mean, peak to peak, or instantaneous. We will come to this later. But there is systolic gradient between LV and aorta. If I ask you, is it normal to have a systolic gradient between LV and aorta or abnormal?
It's abnormal.
It is abnormal because both LV and aorta systolic pressure is around 120. So if I have a systolic gradient between LV and aorta, what does this indicate? Or what does this goes with which diagnosis?
Aortic stenosis.
Aortic stenosis. And when hemodynamics usually will have a peak-to-peak gradient or peak instantaneous gradient. Peak-to-peak gradient, I will determine the peak of the LV, the peak of the aorta, and measure the gradient between them. And this is usually used conventionally in invasive hemodynamics because it is easy and it is conventional. The peak instantaneous, it means the maximum gradient at a specific point of time between the LV and the aorta. So by just looking at this gradient, this indicates severe aortic stenosis. So just try to be familiar with a certain protocol or adopt a protocol to describe hemodynamics so you can get the diagnosis easy. In this one, I will say simultaneous hemodynamic tracing of LV and aorta in a scale of 0 to 200 with ECG in sinus rhythm. This is what we see. LV, peak systolic pressure around 200, LV EDP around 10. It's not high. Aortic pressure 100 over 60 with a slow rising pulse. If I look at the ascending limb of the aorta, it is slow rising, okay? There is significant peak-to-peak systolic gradient between LV and aorta of around 110, indicating severe aortic stenosis. So the diagnosis is severe aortic stenosis. Okay, just try to be systematic, try to adopt a protocol in describing the hemodynamic, whether it is simultaneous or pull back, mention the scale, mention the ECG. Sometimes they will give you respiratory phases. Sometimes will give you a phonogram or a cardiac phonogram. So you have to pay attention for all these because when are present, they have a meaning. We will see in more examples later. Okay, who can take this one?
Yes, I can take it.
Okay, go ahead. Thank you.
Two simultaneous.
Simultaneous hemodynamic tracing of
LV and aorta.
Of LV and aorta in a scale of 0 to 200. Okay, good.
200.
With ECG tracing.
ECG tracing.
In sinus rhythm because there is a P wave here. Okay, good.
Yes. Okay. The pressure in the LV.
LV, aywa, systolic pressure, how much? So this is the LV, this is the LV, okay, around 180.
180. And
okay.
The systolic pressure in the aorta is...
no, just go with 200. The LV. LV systolic pressure 180. Okay, so what about LV diastolic pressure?
Like LV diastolic pressure is about less than 20.
No, end diastolic. This is all diastolic, so this is the end diastolic. This is the end diastolic.
End diastolic is about 40.
40. So now the LV pressure is around 180 over 40. What do you think about this diastolic pressure, end diastolic pressure? Is it high or normal?
End diastolic pressure is high.
Is high. So I get
Yes.
from here, from LV pressure.
And there is
okay, now you can go to the aortic pressure.
Yes, aortic pressure systolic is about 180. And
aorta around 200. Okay, this is aorta.
200, sorry. Yes, 200, and the diastolic is around approximately 60.
Okay, 55 or 60. So 200 over 55 or 60. Okay.
Most probably this patient has severe aortic regurgitation.
So the pulse, the aortic pressure showed wide pulse pressure. The difference between systolic and diastolic is
diastolic is wide. Yes.
Yeah. So you said aortic regate. Why you said aortic regate?
There is a diastolic gradient between the LV and aorta.
Diastolic gradient. Diastolic gradient between LV and aorta is a normal finding. Diastolic gradient. If you are talking about this gradient, it is normal because the LV pressure around 120 over 10. The aortic pressure is around 120 over 80. So you said there is a wide pulse pressure going with severe aortic, wide pulse pressure. The other thing, high LV ADP.
High LV ADP.
And what do you think about this?
Anacrotic notch.
Yeah.
Anacrotic notch, the presence of anacrotic notch also.
Yeah. So diagnosis is severe AI. Okay. So simultaneous hemodynamic tracing of LV and aorta in a scale of 0 to 200 with ECG tracing in sinus rhythm. LV systolic pressure 180, LV ADP 40, aortic pressure 200 over 55 with wide pulse pressure of 145, indicating severe aortic regurg. Also, we have anacrotic notch in the ascending limb of the aortic pressure. So this is indicating severe aortic regurg. So the diagnosis is severe aortic regurg. Good, well done. Who can take this one and just describe what you are seeing and what is given in this hemodynamic tracing?
معاوية.
تفضل يا معاوية. Go ahead.
في زول اختارناه بس.
اوكي شكلك يعني
هو سينيور في الموضوع ده عشان كده اخترت انا ياسين اللي اخترت.
Okay.
This is simultaneous hemodynamic tracing.
Good.
In a scale between the LV and LA.
This is the LV and LA in a scale
of 0 الظاهرة لحد 40.
Of 0 to 40 plus. Okay.
We have pre and post.
Yeah, it seems pre and post procedures. Okay.
Yes. So we have here. We have a gradient. We have an ECG, which shows it seems in a sinus rhythm. Yes.
Normal sinus rhythm. Good.
Normal sinus rhythm. And there is a
just prescribe, Muawiyah, prescribe the pre-procedure, then the post-procedure. Now concentrate on the pre-procedure.
Okay. I can see in the diastolic gradient between the LV and the LA.
Okay, there is the diastolic gradient between LA and LV. What about the LA pressure?
And we have also the LA pressure is high.
It's high.
It is,
yeah. If you, because this variation is most likely due to respiration. But if we took the mean, maybe around 20, the mean left atrial pressure is around 20. And I know that the mean left atrial pressure is around 5 to 8 or something like this. So high left atrial pressure, number one. Number two, there is the diastolic gradient between the LA and LV, indicating what?
Significant mitral stenosis.
أيوة, severe or significant mitral stenosis. So,
also, we have a prominent V wave. I don't know. I have a prominent V wave during systole there.
I think if you concentrate, the whole left atrial pressure goes up and down with respiration, with both A and V wave. So if we took, for example, certain beat, usually to differentiate A from V, I have to look at the ascending and descending limbs. So yeah, this is the ascending, this is the A, this is the V. Here, the ascending, the A and V. Here, ascending, A and V. For example, here, the V is not high. In some beats, it is high, but in such case,
not always.
the mean left atrial pressure is high. And there is the diastolic gradient, okay?
Yes.
What happened post procedure?
So this is most likely balloon valvuloplasty, mecherotomy.
Yeah, describe your right hand.
So on the right hand, we have the this is a hemodynamic tracing, simultaneous hemodynamic tracing between LV and LA.
Good.
السكيل ما ظاهر لي.
هو the same scale يعني 0 to 40. The same scale.
And there is significant reduction in the diastolic gradient between LV and LA.
Good.
During diastole.
There is a significant reduction in the diastolic gradient between LV and LA. This is number one. What about the left atrial pressure?
Also, it drops significantly.
Yeah, there is a reduction. Yeah, so there is drop of left atrial pressure and significant drop in the diastolic gradient between the LA and LV. So this means the degree of mitral stenosis, if we calculate in numbers, maybe this is around 5. So decrease from severe to mild. So this most likely patient underwent what type of procedure, pre and post?
This is balloon valvuloplasty.
Yeah, because we have hemodynamic tracing. This means in the cath lab, we have this hemodynamic tracing. We have the same scale. Most likely, what we will do in the cath lab is mitral valve ballooning or balloon valvuloplasty. So simultaneous hemodynamic tracing of LV and LA in a scale of 0 to 40 with ECG and sinus rhythm. Pre-procedure, we have high left atrial pressure, more than 20, or mean of 20. Then we have with significant diastolic gradient between left atrium and LV, indicating severe MS. Post-procedure, both the diastolic gradient and left atrial pressure drop down. So drop of left atrial pressure to 5 and significant drop of the diastolic gradient between LA and LV. Now severe MS decreased to mild. Diagnosis is severe MS with successful mitral balloon valvuloplasty. Okay? Who can take this one, please?
Excuse me.
Sorry, but
yes,
just allow me. For the last slide, there was a similar tracing, and the answer was the control of heart rate. So there was a tracing of MS with a high gradient that becomes low. And the answer was beta blocker was given. Because remember, it's not always about intervention. Mitral stenosis gradient is so responsive to heart rate control. So if you see a difference in the heart rate between the left side and the right side, that might be the answer.
You are right. You are absolutely right, Hakim. But if we have this tracing in the cath lab and it is written pre and post, for example, said procedure, most likely valvuloplasty. But if you notice a significant drop in the heart rate between pre and post, so this may be an effect of the beta blocker. So pay attention or be open-minded for all possible intervention, maybe medication or procedure. Thank you, Hatim. Who can take this one? Okay, any volunteer?
Yes, I can take it.
Okay, go ahead. Thank you.
Okay, this is
now you can figure out the shape of the hemodynamics, whether it is, for example, ventricular, arterial, which artery, which ventricle. You can figure out from the shape of the hemodynamic tracing, and it is written down just LV and aorta.
Yes. Okay. طيب the red one, the tracing of the red one, the LV and the
simultaneous hemodynamic tracing of LV and aorta with ECG tracing showing normal sinus rhythm. Any other thing in the ECG?
Yes, there is premature ventricular contraction.
BBC. Okay, good, good. Describe what you see for which one is the LV and which one is the aorta?
Okay, the type. Okay, the LV is the red one.
Usually,
no. Excuse me. The LV is the yellow one, and the white.
The LV is the yellow, and the orange one is the aorta.
It's the aorta.
Describe what you are seeing.
Okay. There is a variation in the maximum systolic
we call it gradient. We call it gradient, systolic gradient. There is significant systolic gradient between LV and aorta.
Yes, and I mean, even in the aorta, there is variation in the systolic peak.
You mean pre-BVC and post-BVC?
Variation, yes.
Yeah, so let us concentrate before the BVC. Before the BVC,
before the BVC, there is a systolic gradient between the aorta and LV.
Okay, there is systolic gradient between LV and aorta. What happened after the BVC? Describe what happened. Yeah.
Okay, after the BVC, there is increase in the gradient between the LV and the aorta because of increasing in the LV systolic pressure and decreasing in the aorta systolic pressure.
Number one, post-BVC, there is increase in the systolic gradient. Good, excellent. What other?
Decrease in the aorta, aorta big
there is decrease in the aortic systolic pressure and maybe the same diastolic pressure. So if I ask you about the pulse pressure here, the difference between systolic and diastolic aortic pressures, what about before BVC and after BVC?
طيب نحن قلنا before the BVC إنه في decreasing في الأورطة.
Okay.
Increase in the gradient. يعني the increase in the gradient due to decrease in the aortic pressure and increasing in the LV pressure at the same time.
Yeah, you are right, absolutely right. But now I'm asking about pulse pressure in the aortic tracing. Pulse pressure.
Mm-hmm.
What do you think?
There
is a decrease in the aortic pulse pressure. This is number two. Number one, there is increase in the systolic gradient between the LV and aorta post-BVC. Number two, there is a decrease in the aortic pulse pressure post-BVC. Number three, what about the shape of the aortic hemodynamic tracing pre-BVC and post-BVC? Does it mean something for you? The shape of the aortic hemodynamic, okay?
Yes, يعني it's go more slowly.
Okay. What about the shape, overall shape of aortic
it takes more time.
This appearance usually described as spike and dome.
Spike and dome.
Yeah. So these findings suggest diagnosis of what?
Dynamic obstruction.
Dynamic LVOT obstruction or hypertrophic cardiomyopathy. Excellent.
Myopathy.
So this is simultaneous hemodynamic tracing of LV and aorta with ECG tracing showing normal sinus rhythm with a BBC. There is significant systolic gradient between LV and aorta. This is the systolic gradient between LV and aorta, which increased after the BBC with reduction in the aortic pulse pressure. This is called broken pro sign. This happened in LVOT obstruction, dynamic LVOT obstruction or hypertrophic cardiomyopathy. Aortic pressure showed spike and dome configuration. This also supports diagnosis of hypertrophic obstructive cardiomyopathy with dynamic LVOT obstruction. Okay?
Okay, thank you. والله يا بص شكرا لك ريلي لانه يعني انا ولدت اولاد عشان اقول الكلام ده وسيمبل مكتوب بطريقه مرتبه جدا.
Okay, thank you. We are here يعني just I brought this to give you a protocol to adopt, so everything will be easy inshallah if you take it systematic. Okay, who can take this one? And it is a bit difficult. يعني I prefer F2 or F3 if rather than F1. Okay, who can take it?
Okay, okay, I will try to take it.
Okay, good.
This is ما pull back. This is hemodynamic tracing. ما في حاجة مكتوبة لكن it seems of the right side of the heart.
From the shape of hemodynamics, what?
Yes.
We have three parts. Here we have on our left hand, here in the middle, and here in our right hand. Try to figure out, because you have a scale, for example, of 0 to 200. Try to figure out which possible chambers or vessels will be this one.
This is most likely swan gas catheter. Because,
okay, from where?
From RA to the LV and then to the pulmonary artery. With an ECG.
You said from pulmonary capillary wedge pressure to?
No, not from the RA to RV.
From RA to RV to?
Pulmonary artery.
Pulmonary artery.
أو ممكن العكس طبعا ممكن تكون pull back.
Okay.
This is pulmonary capillary wedge pressure.
Okay.
This is a pulmonary artery pressure. And this is the RV pressure. There is a significant gradient between the pulmonary artery and the RV.
If you concentrate here, maybe the shape is similar to this one. So the shape in the middle is similar to the shape on my right hand. And overall, it resembles a ventricular hemodynamic tracing.
Yes.
So looks like RV, agree with you. So if it is a withdrawal or pullback, it will be from pulmonary artery to RV. But here in RV, I have what looks like intracapillary or intraventricular gradients. If we notice this letter A and letter B indicating significant gradient. Let me continue. So if I want to describe this, I will say this is hemodynamic tracing during withdrawal from pulmonary artery to RV with ECG in sinus rhythm here, okay? Then the pulmonary artery pressure is around, maybe this is 50, say 20 over maybe 5. Pulmonary artery pressure around, for example, 25 over 5, something like this. Then from the pulmonary artery, it seems that we are in the RVOT. There is a gradient from pulmonary artery and RVOT. So if I have a gradient, systolic gradient from pulmonary artery and RVOT, what is the structure between the pulmonary artery and RVOT? Is a pulmonary valve. So, and this gradient, the A, is systolic gradient because this is the maximum systolic pressure. This is the maximum systolic pressure. So there is a systolic gradient between the pulmonary artery and RVOT, indicating valvular pulmonary stenosis. Then pulling or withdrawing from the RVOT to the RV cavity, there is another gradient, which is P. This is from the pulmonary, from the RV cavity to RVOT. I have here a systolic, again, a systolic gradient. So there are two gradients. One, the A is for between the pulmonary artery and the RVOT, and the other one is between the RVOT and the RV cavity, which is infundibular. I have valvular and infundibular systolic gradient, and this usually occur in case of
PSD. Tetralogy.
Fallot tetralogy. Excellent. Good. Yes. Fallot tetralogy. So this is the typical description. Hemodynamics tracing recorded during withdrawal from pulmonary artery to RV with ECG in sinus rhythm. Pulmonary artery pressure is around 20/5, I said before. There are two, one RVO2 to pulmonary artery systolic gradient of 45. This A, sorry, this A around 45 indicates valvular stenosis, and there is another one between the RVOT and the RV cavity, and we have high RV systolic pressure of 170. So above finding indicates severe valvular and subvalvular pulmonary stenosis, and this goes with diagnosis of Fallot tetralogy. So now we'll take further example, try to utilize the way we are describing, and just who can describe this one?
I am here.
Okay, go ahead.
This is simultaneous hemodynamic tracing.
Okay. Okay. Simultaneous hemodynamic tracing
between the LV and the aorta is scaling between 0 to 100.
0 to 200.
There is no ECG.
Okay. If it is there, don't mention it. But you have something to help you. SEP. This is systolic ejection period. Okay.
Yes. The LV pressure is the systolic LV pressure is 200.
Okay. 200.
And the diastolic is about 40.
No. If this is 0, 100, this is 50. This is around maybe 20 or 15. Okay.
20. The aortic systolic pressure is around 160.
160 or 70. Okay. And the diastolic?
It's around 70 or
70,
60.
75. Okay. What about this shaded area and letter A and letter B? What do you think?
This is the mean gradient.
Systolic or diastolic?
Systolic.
Yeah, we have systolic gradient between LV and aorta, which is abnormal. If we have systolic gradient between LV and aorta, it is abnormal. So what is the letter A and the arrow here indicate? I mentioned before, we have two, in hemodynamics, we have two, the description of systolic gradient can be in one of either way, either peak to peak or instantaneous. So which one is the peak to peak and which one is the instantaneous gradient? Peak instantaneous gradient. Which one?
B is peak to peak.
B is peak to peak. So the maximum here,
B,
so B is the
peak to peak.
And A is the peak instantaneous gradient. And usually, as I said, in hemodynamics, we use peak to peak gradient, or conventionally use, because it is easier to measure. It is easier to measure. So it is easy to identify the peak here, easy to identify the peak here, and measure the peak to peak gradient. And here, the peak to peak gradient is around, if I have this, for example, 50, maybe around 25 or 30. So it goes with diagnosis of mild aortic stenosis. Mild aortic stenosis. Okay? Thank you very much. Well done. Who can take this one?
Okay, I can take it.
Okay, go ahead. Go ahead.
So this is simultaneous hemodynamic tracing between the LV and the aorta in scale between 0 to 200.
Okay,
the LV tracing, the peak is 120, and the LVEDP is around 40.
So LVEDP is around 40.
40 high.
So the LV is the red one, the aorta is the blue one. Okay, LVEDP is high. Good, good, good bit. Okay.
So the aorta, the
concentrate
peak aorta
on the arrows. What this arrow mean and what this arrow mean? So the aorta, this is the diastolic.
Yes, this is diastolic. End-diastolic. Yes. And this is diastolic gradient. The other arrow.
So in the aortic pressure, number one, we have nearly equal, or we have a narrow end diastolic left ventricular and aortic pressure.
Yes, equalization of the pressure between the aorta and the LV.
Yes. And the other thing, we have marked increase and rapid rise of diastolic pressure.
Yes.
So with rapid rise in aortic diastolic pressure, high LVEDP, and almost narrow end diastolic left ventricular and aortic pressure. This support the diagnosis of
severe aortic regurgitation.
Severe aortic
AR.
Yeah.
And decompensated.
Most likely acute. Most likely it is acute. Why? Why it is acute? What about the pulse pressure here? The aortic pulse pressure?
There is no wide pulse pressure.
So the aortic pulse pressure is not wide. This supports the diagnosis of acute severe AI or acute AI. At this point, we have only increased LVEDP and a rapid rise in the aortic diastolic pressure, but the aortic pulse pressure is not that so wide. So this goes with acute, Okay, what about this one? If we apply the same for the previous tracing, here maybe the difference is wide aortic pulse pressure. So this indicates chronic aortic regate. There is high LVEDP and there is wide pulse pressure, and there is narrow end diastolic left ventricular and aortic pressure, and there is marked increase and rapid rise of aortic diastolic pressure. So just to differentiate between chronic and acute AI, this is acute and this is chronic. Okay? So who can take this one? And just to help you, your left hand diagram is normal. your right hand is abnormal. Who can describe? Just describe what you are seeing. That we will reach diagnosis. If you mention all the finding, ultimately we will reach a diagnosis.
Okay.
And I help you. Your left hand tracing is normal. Your right hand tracing is abnormal.
You can
Okay,
take it,
this
but
is...
the network is very bad.
Okay, who can go ahead?
Okay, this is simultaneous tracing.
Okay,
on the right side, in a scale between 0 to 40, it seems like between the RV and the pulmonary capillary wedge pressure.
So if you notice, this is ventricular. Am I right? The yellow one is ventricular. What do you think about this ventricular pressure? It's high, higher, yani it seems.
It's high, yes.
Higher for the RV. So most likely this is LV.
Pulmonary stenosis.
No,
yes.
this is most likely LV. And here in the atrial pressure or pulmonary capillary wedge pressure, you already have A and V. So this is pulmonary capillary wedge pressure or left atrial pressure because they resemble each other. Okay?
Yes, yes.
So what is the finding? In general, without specification?
We have a diastolic gradient also.
Yeah, if we have a diastolic gradient between LV or pulmonary capillary wedge pressure or left atrium, so this indicates a diagnosis of
mitral stenosis.
Mitral stenosis. If I ask you a question, other than the diastolic gradient, what other findings support the diagnosis of mitral stenosis from this hemodynamic tracing? What other findings?
Very big A wave.
Excellent.
A wave is speaking.
Large A wave support the diagnosis of mitral stenosis. Excellent. Okay, well done. Who can describe this?
Okay, also this is hemodynamic tracing.
Hemodynamic tracing of? Here it is written.
The LV and pulmonary capillary wedge pressure.
Excellent. Okay.
We have an ECG which shows atrial fibrillation. It is not regular.
Excellent. What other support other than irregular heartbeats? What support your? Because if we look, this is systole, this is systole, this is systole, this is systole, this is QRS complex, QRS complex, QRS complex. It is completely irregular. So if I ask you what support your diagnosis of atrial fibrillation in this tracing, I mentioned it earlier.
There is no A wave.
There is no A wave. Excellent. There is no A wave. We will see only high V wave, or there is diminished A wave. Okay, excellent. Go ahead. So LV, pulmonary capillary wedge pressure, simultaneous hemodynamic tracing, scale of 0 to 50 plus, ECG in atrial fibrillation.
Yes,
what are the findings?
LVEDP, it seems around not so high.
So if this is 50, so each one around 5. LVEDP is around 10. Okay, it is not high.
Yes, and we have a prominent V wave.
Prominent V wave with high pulmonary capillary wedge pressure. The V wave around 25.
Yes.
So this goes with the diagnosis of
significant mitral regurgitation.
Mitral regurgitation. Okay.
Mitral, because this is pulmonary capillary wedge.
Yeah, it is pulmonary capillary wedge or left atrial and LV. This goes with mitral regurgitation. What about the shaded area? This area and also this area.
This is the diastolic gradient also.
Diastolic gradient between the left atrium and the LV.
Yes.
Going with diagnosis of?
Mitral stenosis also.
So if I want to put a diagnosis, atrial fibrillation, mitral stenosis, mitral regurg, most likely also rheumatic heart disease. Excellent.
Mitral regurg.
Yes, mitral regurg because of the high V wave, and mitral stenosis because of the diastolic gradient. The pulmonary capillary wedge pressure resembles the left atrial pressure, and it is high. And there is a diastolic gradient, and there is atrial fibrillation. Also, most likely this patient has rheumatic heart disease, atrial fibrillation, MS, or mixed mitral valve disease. Okay? Who can take and describe this one? Concentrate on description. Trust me, diagnosis will come easy.
I can take it.
Okay.
This is hemodynamic tracing, simultaneous hemodynamic tracing.
Okay.
Between the LV and the pulmonary capillary wedge pressure.
Which one is the LV and which one is the pulmonary capillary wedge pressure?
The red yes. is the pulmonary capillary.
The scale is 0 to 200. So the blue one is
the LV.
LV. And the red one is around 100 over 80 or 70. 100 over 70. So this goes with, and from the configuration or from the shape of hemodynamic tracing, it goes with which vessel or chamber? This it goes with aorta. Goes with aorta.
Yeah. Aorta
because,
and
yeah. So
aorta
this is LV and aorta.
Yes.
Yeah.
Showing systolic gradient between the LV and the aorta. And gradient between the LV.
So what happened for the LV catheter? I have two catheters, one in the aorta and another catheter in the LV. What happened for the catheter in the LV?
There is two gradients between the LV and the aorta and between the LV.
Yes. In other words, if I took the tracing from my left hand to the right hand, so concentrating on the LV catheter or hemodynamic, there is a withdrawal or pull of the LV catheter from LV cavity to LVOT. Agree? Because the same shape of ventricular tracing. So in the LV cavity, there is a systolic gradient between the LV and the aorta. When we reach the LVOT, what happened?
The gradient drop.
No gradient.
So yeah, in subaortic area or in LVOT, there is no gradient. So, or there is a reduction in the systolic gradient between the LV and aorta in the subaortic area or in the LVOT. So
that
this
means
support the diagnosis of
mid cavity obstruction most
either aortic stenosis or
dynamic
mid cavity.
Yeah, it supported dynamic LVOT obstruction because I moved from mid cavity to LVOT here or subaortic area. This is the LV catheter. So this support the diagnosis of dynamic LVOT obstruction. Also, if you concentrate on the aortic hemodynamic tracing, what is the configuration of this aortic hemodynamic configuration? I mentioned
spike and dome. Spike and
showed
dome.
spike and dome. This further support a diagnosis of hypertrophic obstructive cardiomyopathy. Okay?
Yes. Yes.
Okay. So here, just to show you the difference between aortic stenosis and hypertrophic cardiomyopathy, I gave you the diagnosis in ECG with BBC. So what happened? We already mentioned this example in hypertrophic cardiomyopathy. There is increase in the systolic gradient and there is a reduction in the aortic pulse pressure. This is known as pro sign. This confirms a diagnosis of hypertrophic cardiomyopathy. But in aortic stenosis, what happened? Anyone can describe in aortic. So this is slide to differentiate between aortic stenosis or fixed valvular aortic stenosis from dynamic LVOT obstruction of hypertrophic cardiomyopathy. We already described the hypertrophic cardiomyopathy. So anyone can describe the change in aortic stenosis or in fixed stenosis?
Yes, in case of aortic stenosis.
Aywa. What happened in the post-BBC?
There is increase in the pressure in the aorta and in the LVOT at the same time.
Systolic. And what about the pulse pressure?
The pulse pressure will decrease.
There is wide. The pulse pressure here in HOCM, it decreased. Here, it is wide or increased or the same. Here, it is increased. The pulse pressure in
the HOCM and increase in the aortic stenosis.
Decreased in HOCM, increase in aortic stenosis. The other thing, the configuration here is spike and dome in HOCM, and there is no spike and dome in aortic stenosis.
Spike and dome.
Yeah. Also, if you concentrate, this
in case of aortic stenosis,
the rise in aortic pressure in case of aortic stenosis, it is slow. The rise in aortic pressure in case of aortic stenosis is slow, and in case of hypertrophic cardiomyopathy, it is sharp or vertical. The rise here is vertical, here it is slow. So this is one of the differentiation between aortic stenosis and hypertrophic cardiomyopathy. So to just summarize, in aortic stenosis, post-BBC, there is a slow upstroke of the systolic pressure, there is wide pulse pressure, and the same waveform for aortic pressure. In hypertrophic cardiomyopathy, there is a vertical or sharp increase in the upstroke of the aortic pressure. There is a narrow pulse pressure. There is increase in the systolic gradient, and there is a spike and dome configuration of the aortic pressure. Is it clear?
Yes.
Yeah.
Okay. So who can just digest what we said and apply it here? I think by now we can be more quick and in interpreting this. So who can interpret this one?
This is simultaneous hemodynamic tracing between the LV and the aorta, showing increase in the
with ECG showing ECG هنا مهم. The ECG is important here.
And the LV aortic pressure with gradual raise in the aortic pressure.
You have to mention the ECG and the finding in the ECG, please. Okay, the ECG.
Post BBCs.
With post BBC. Okay, what happened?
There is gradual raise in the systolic pressure of the aorta with the raise in the systolic pressure in the LV, and
so there is increase in both LV and aortic systolic pressure, and increase in the aortic pulse pressure. Excellent. With a slow rising in the
yes.
aortic pressure or upslope. So what is your diagnosis?
It is aortic stenosis.
Aortic stenosis. Excellent. So aortic stenosis, increased pulse pressure post BVC. Okay. So who can take this one?
This is simultaneous hemodynamic tracing between LV and the left atrium, showing
excellent. With ECG tracing. ECG tracing, don't forget, and scale.
With ECG tracing showing which is sinus. There is high.
I told you, are you sure it is sinus? Defend yourself.
No.
Why it is sinus?
Yes.
Is there any P wave?
No.
No P wave. Okay. Is there any A wave in the left atrial pressure?
There is P wave. No, there is no A wave.
So there is no
loss
A wave.
of A wave.
So this is atrial fibrillation. ECG in atrial fibrillation. What is the finding?
And there is high V wave.
There is a high V wave indicating high left atrial pressure of around 70 because the scale is from 0 to 100. So this is 75. It is almost 75. Okay.
So the most likely it is the mitral regurgitation.
Yes, this is most likely isolated severe MR and atrial fibrillation. What about LVEDP?
It is
here
low around
25. Here around 25, maybe around 10 to 15. 10 to 15. So LVEDP is not elevated. So this is most likely isolated severe MR in a patient with atrial fibrillation. Excellent. Well done. Okay. So who can take this one?
Okay, I can take it.
Okay, go ahead.
This is a simultaneous hemodynamic tracing between the LV and LA in a scale between 0 to 80. And ECG tracing, which showed the atrial fibrillation.
Excellent.
There is a diastolic gradient between the LV and LA.
Excellent. Indicating what?
Severe mitral stenosis. Yeah, significant mitral stenosis.
Mitral stenosis, okay.
It is severe. LA pressure is very high.
And what about the...
Also, we have...
What about the V wave? We usually look at the descending limb of the LV, the descending limb.
We have a V wave about around 30. Around 30.
30 to 40. Yeah. So high V wave. This indicates a diagnosis of?
Significant mitral stenosis.
Mitral regurg.
MR, sorry. MR,
yeah, yes. MR. So this patient is having atrial fibrillation, MS, MR. Yes. Now you see how easy you can get the diagnosis if you systematically interpret the finding you have. Okay. Who can tell me about this tracing?
Also, this is hemodynamic tracing between RV and RA.
Okay.
in a scale between 0 to 40.
Excellent.
There is a giant systolic V wave, which indicates severe tricuspid regurgitation.
Yeah, and there is high right atrial pressure. The right atrial pressure almost 20. So there is high right atrial pressure, and the right atrial waveform closely resemble the RV waveform, but it is to lesser extent. So this goes with the diagnosis of severe TR. Yeah, the RA waveform closely resemble the RV waveform in severe TR. Excellent. Okay. Who can take this one? If I told you this is
yes, this is the simultaneous.
This is RV and RA. RV and RA, because the pressure here around 40 plus. Okay. Yes. So simultaneous hemodynamic tracing. Okay, go ahead.
Between the RV and the RA with ECG, which is sinus, there is A wave.
Excellent.
And there is the systolic gradient between the RA and the LA, between the RA and the RV.
So if you have a diastolic gradient between RA and RV, and which pressure is higher here? In the diastole, is it the right atrial or the RV pressure? Which one is high?
The atrial pressure.
Yeah, if I have a diastolic gradient with higher pressure in the atrial side and lower pressure in the ventricular side, this supports the diagnosis of we are in the right side. Tricuspid stenosis. Yeah, tricuspid stenosis. Excellent. Just here, it is another, here it is written the diagnosis, hemodynamics of rheumatic valvular tricuspid stenosis. So this is the RV, this is the RA. There is the diastolic gradient between the RA and RV. This is exactly what's seen in the tricuspid stenosis. The same like example we just have seen here, okay? So now I want to describe what is he seeing. Yani it is written, but try to be as systematic. The diagnosis is written, but describe.
There is this is a simultaneous hemodynamic tracing between the RV and the pulmonary capillary wedge pressure.
No, it is pulmonary artery. It is written RV and pulmonary artery.
Pulmonary artery.
Okay.
And, yes.
The scale is not given, but what other given here? ECG?
Yes.
Respiratory phases and phonogram. Okay. So yes. In the phonogram, what is written?
There is S wave and A wave.
Phonogram means the heart sound. The heart sound. So S1 is the first heart sound. A2, P2, the components of second heart sound. Here, ESM, ejection systolic murmur. And what you see here,
there is gradient.
Is it systolic or diastolic?
Diastolic gradient.
You mean this one?
Yes.
So diastolic gradient between RV and pulmonary artery, is it normal or abnormal?
It's abnormal.
Diastolic gradient, we can get it between the pulmonary artery and RV. But the systolic gradient, what about this systolic gradient?
We have very high systolic gradient. The RV pressure is very high and the pulmonary artery pressure is very low. So we have a significant gradient between the pulmonary artery and the RV. Yes. Yes, systolic gradient.
Systolic gradient between RV and pulmonary artery with ejection systolic murmur and split of the second heart sound, and this supported diagnosis of
severe pulmonary
valvular
stenosis.
pulmonary stenosis. Okay. Yes. Oh. Okay. Just here I wrote the diagnosis. Just I want you to describe. Here again, simultaneous hemodynamic tracing between the RV and pulmonary artery with ECG tracing, respiratory phases, phonogram, and there is systolic gradient between RV and pulmonary artery to lesser extent than the previous one. So this goes with mild valvular pulmonary stenosis. And we have systolic ejection murmur. We have first heart sound, second heart sound, with which is split. So this one is severe pulmonary stenosis. This one is mild pulmonary stenosis, severe, mild. Okay. So because now we are short in time, I think we have to be a bit faster. If I told you this is aortic hemodynamic tracing, describe what you are seeing. This is aortic hemodynamic tracing. So what do you see here?
There is gradient in the aorta.
We have only one vessel, only aorta. We have, in aorta, usually pressure is phasic, systolic, diastolic. We have normal value of 120/80 around this one. So what happened? So this is hemodynamic tracing of the aorta with ECG tracing.
ECG, which shows electrical alternance.
Drop in the aorta.
Just concentrate, see what happened in the aortic pressure. The ECG, what do you think about this ECG?
Drop in the aorta.
It is sinus tachycardia and there is electrical alternance in the ECG.
So, okay, is it electrical alternance? I mean beat to beat variation or something else?
No, it is not beat to beat.
Yeah, it is sinus tachycardia. Now go back to the aortic pressure. So starting from here, for example, systolic, maybe around 130/80 or 75. Then there is a reduction in the aortic systolic pressure and diastolic pressure until severe reduction in the aortic pressure. So this happened after many beats. Then there is increase again in the aortic pressure. So here we have no respiratory form, for example, for inspiration, expiration. I mean, if you look at the aortic pressure here and aortic pressure here, here it is normal or high, here it is very low, again it is high, here it is low. What do we call this?
Patent ductus arteriosus.
Pressure damping.
This is, we call it pulsus paradoxus. Pulsus, yeah, this is aortic pulsus paradoxus. So there is decrease in blood pressure with respiration. I have no respiratory form here. But if I can imagine, for example, if I calculate, for example, from here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, almost 15 heartbeat. At least there is a phase of inspiration and expiration. At least one phase of inspiration, expiration, and there is a change in the aortic pressure with respiration. So there is a reduction or decrease in aortic or in blood pressure with respiration, and we call this pulsus paradoxus. Okay? So pulsus paradoxus with complete obliteration of the arterial pressure with inspiration. Just a reminder for the causes of pulsus paradoxus. It could be pericardial tamponade, effusive constrictive pericarditis, right ventricular infarction, severe bronchial asthma, or severe COPD, severe congestive heart failure, obesity, but not to this extent usually, ascites, pregnancy, pulmonary embolism, and tension pneumothorax. These are the common causes of pulsus paradoxus. Okay? Who can just hear the diagnosis is written? I just want you to describe what you are seeing. Diagnosis is written here.
Okay, and the constrictive pericarditis is simultaneous hemodynamic tracing between the LV and RV.
Okay, so this is left and right heart catheterization. We said one of the indications to differentiate between constrictive pericarditis from restrictive cardiomyopathy. So what you see in the left hand or constrictive pericarditis?
In during we have a respirometer. During inspiration, the LV pressure drop and the RV pressure increase.
So this is physiological.
Discordant.
Yeah, physiological. When you have inspiration, because of negative intrathoracic pressure, the pressure in right side of the heart will increase. So there is increase in the RV pressure with inspiration.
Yes.
And because we have a constrictive pericarditis and the pericardium is constricting the expansion of the ventricles, so, and with increasing volume in the right side, to adopt this increased volume, the septum have to move towards the left ventricle, from the right ventricle to left ventricle. This will lead to decreased volume in the left side. So with inspiration, I have increase in the right ventricular pressure and decrease in LV pressure. And this is discordant. So discordant change in LV and RV systolic pressure during respiration. And this is occur with constrictive pericarditis because the septum will pose towards the left side. First, the pressure will increase in the right side. Septum will go to the left side, will cause impedance of the LV filling, and the pressure in the LV will go down. And this is because the constriction is from outside the heart. The myocardium here is normal. The septum is normal. So the constriction is from outside the myocardium, from pericardium. If we go to the example on our right hand, who can describe?
This is a simultaneous hemodynamic tracing showing LV and RV at the same time. In inspiration, there is increase in the LV. During expiration, there is increase in LV pressure. At the same time, there is increase in the RV pressure.
So the change in LV and RV pressures are concordant. Yeah. Why concordant? Because the myocardium here is restricted or stiff. So the septum also is stiff. Any change in the left side, any change in the pressure in the right side, there will be a change or increase in the left ventricle. So the change in LV and RV will be concordant in case of restrictive cardiomyopathy. Yeah, this is a physiology and it is a great topic. Just I bring example because our topic is only hemodynamics. So, and by the way, invasive hemodynamic is a gold standard in differentiating or diagnosing constrictive pericarditis or differentiating it from restrictive cardiomyopathy. Just take it, what we will see in hemodynamic of constrictive pericarditis and restrictive cardiomyopathy. It will be the change in LV and RV systolic pressure or pressure will be discordant in case of constrictive pericarditis and concordant in case of restrictive cardiomyopathy. Okay, who can analyze this one? Just utilize what we said.
This is a hemodynamic, simultaneous hemodynamic tracing with with
of LV and RV.
Between the LV and RV, scaling between 0 to 100 with ECG, which is sinus, showing there is exaggerated discordance between the LV and RV.
So the change in pressure between LV and RV with respiration are discordant. So if there is increase in the RV, there will be a decrease in LV. So the diagnosis is?
Constrictive pericarditis.
Excellent. Constrictive pericarditis. So what about this?
Simultaneous hemodynamic tracing between the LV and RV with ECG, which is sinus, scaling between 0 to 180, showing discordance between the LV and the RV.
Where is the discordance? No. Where is the discordant? Is it discordant or concordant? Just go bit by bit. So here the LV, here it is decreasing, صح? From 1 to 5, it is decreasing. So the RV, it is decreasing. Here, both decrease. Here, both increase. So is it discordant or concordant?
Concordant.
Okay. So what is the diagnosis?
Restrictive cardiomyopathy.
It is restrictive cardiomyopathy. Okay, this is just a schematic representation. Patient with constrictive pericarditis with inspiration, there is increase in the RV pressure, decrease in the LV pressure. So there is a discordant change in pressure between the LV and RV. Here in restrictive myocardial disease or restrictive cardiomyopathy, there is a concordant increase and decrease between the LV and RV pressures. Take it simple like this. Is it clear? So few words about intra-aortic balloon pump. For the physiology, for the effect of the intra-aortic balloon pump, I think you have to read about it and how it changed the physiology and how it helped and how it improves the coronary blood flow and perfusion. But few words, the intra-aortic balloon pump usually will be impeded or incorporated into the aortic hemodynamic or aortic pressure. Usually intra-aortic balloon pump, we have inflation and deflation. The inflation will be timed as the dicrotic notch of the aortic. So if we start from here, this is the unassisted without intra-aortic balloon pump, the unassisted diastolic pressure. Then increasing, this is the filling, this is the unassisted systolic pressure. Then we'll go to the down limb of the aortic pressure, and here we have the dicrotic notch. This is the ideal time for intra-aortic balloon inflation. So the proper timing for inflation will be with dicrotic notch. Then we'll get this fall. Now the intra-aortic balloon pump incorporated in the aortic pressure, and we will get this. This is systolic augmentation. This is systolic augmentation. Then we have the deflation, and we have the assisted or diastolic pressure following the intra-aortic balloon pump. And here in this example, the setting of the intra-aortic balloon pump is 2-to-1. This one is assisted, this is not assisted. So I will go back here to the ascending limb of the aortic pressure, and this is the dichrotic notch and without intra-aortic balloon pump. Just, I will not go into details. I will show you the common shape of intra-aortic balloon pump. So here, the A showed the normal aortic hemodynamic tracing. The ascending limb, the dichrotic notch, descending limb, ascending limb. This is the normal aortic pressure. If I have an intra-aortic balloon pump with augmentation of 2-to-1, so this is the initial aortic pressure. Here, the inflation of the intra-aortic balloon pump with the dichrotic notch, then deflation, then this one is not assisted. There is no intra-aortic balloon pump. Then the following one with intra-aortic balloon pump and vice versa. Okay, so this is normal aortic. This is augmented or assisted aortic with intra-aortic balloon pump. For the common incorrect timing, so if I have this ascending limb of the aorta and before reaching the dichrotic notch, if the intra-aortic balloon pump is inflated, we call this situation early inflation. So the augmentation is started before the dichrotic notch. This is the shape for early inflation. Early inflation. It comes before the dichrotic notch. Okay. This is the late inflation because this is the ascending limb. This is the descending limb. This is the dichrotic notch. After the dichrotic notch, the intra-aortic balloon pump is inflated. So this is late inflation. Also for the deflation, this is proper inflation, but early deflation. Early deflation. And this one is late deflation. You see here, it is early, and here it is late. And with it is changed in the aortic pressure. So just try to put this figure into your mind. So you will have the common incorrect timing of intra-aortic balloon pump with first example showing early inflation, and this is the correct timing. This one showed late inflation, and this is the correct timing, early deflation, and late deflation. I will not go into details. I just brought it as an example for you. Okay? So you have to go back, read about the physiology of intra-aortic balloon pump, how to get benefit of it, and what are the consequences of incorrect timing. For example, early inflation, what will happen? Late inflation, what will happen? Early deflation, what will happen? And late deflation, what will happen? Because this is a huge topic, and now we are just taking example for hemodynamics. Who can take this one? شباب مصحصحين ولا نايمين؟
This is صحيحين والله يا دكتور عوض. This is pull back catheter.
This is
from the LV to the LVOT.
From LV, this you mean on my
LV,
left hand?
yes.
Okay, this is LV. The LV because the figure looks like LV. Okay.
Tracing of the aorta. Hemodynamic tracing.
Is it simultaneous or pullback or withdrawal? It is pullback. Am I right? Okay.
Pullback, yes.
And so, the next is between the LV and the aorta.
So you mean the first chamber here is the LV, yes, and here is the aorta. Okay. So from the shape, it is LV. From the tracing from 0 to 100, it is LV. The pressure around 120/10. This is LV. You are right. So here from LV to aorta, Agree? The shape is arterial and the pressure goes with the aorta. Okay. What you see here?
About showing intra-aortic balloon pump with with late inflation.
This one, there is no intra-aortic balloon pump. Just to help you, there is, this is the LV. Okay. This is the aorta. What's this arrow point to? This arrow, double head arrow. There is systolic gradient between LV and aorta.
Yes.
Indicating
severe aortic stenosis.
Aortic stenosis.
Yes.
Here, if we have peak to peak, maybe around here 20, maybe around 30, 35, something like this. Okay.
Okay. Yes.
So goes with the diagnosis of aortic stenosis.
Stenosis, yes.
So now we are pulling from LV to aorta. Okay. What is this tracing? The shape is pointing towards. Remember, usually the hemodynamics in real life are not so smooth like what we see in our examples. Yani, this is, when you have a hemodynamic tracing in the cath lab, it may not be that very smooth, but the overall shape will give you an idea which vessel or which chamber we are within. So
the pulmonary, most
pulmonary artery or so how we get from aorta pulmonary vein. This looks like ascending limb, descending limb, ascending limb, descending limb, maybe a dicrotic notch here, dicrotic notch. So this is pulmonary artery. So what happened here as the timing of this question mark?
Gradient. There is gradient between the aorta and the pulmonary.
So if I ask you how many catheters I'm using in this hemodynamic tracing, how many catheters?
2 catheters.
1 catheter.
So is it simultaneous hemodynamic tracing or a pullback or withdraw?
No, it is withdraw.
It is only 1 catheter. Why? Because at one time I have only 1 tracing. At one time I have only 1 tracing. Agree? This is LV to aorta. Yes. So from aorta, this looks like pulmonary artery. So how can I get from aorta to pulmonary artery?
Crossing the atrium.
PDA.
Excellent.
Patent
ductus artery. So from aorta, I went to the pulmonary artery through patent ductus arteriosus. So now I have 2 diagnoses, aortic stenosis, patent ductus arteriosus. And then from pulmonary artery to, what is this tracing?
RV.
This is the RV. Excellent. So this is catheter pullback from LV to aorta with systolic gradient, then through PDA into pulmonary artery, and finally into the RV. So any question? I think we can conclude here. Thank you very much for your attendance, for participation, and really, I enjoyed doing hemodynamics with you.